Are there people online? There are. Okay. Welcome to today's clinical meeting. And we have 5 cases today. And we'll start with Blessy's case from Medicine 1.
Good morning, everyone. On the behalf of Medicine Unit 1, I'll be presenting on the topic, the pituitary drama. So this is a 61-year-old gentleman who is working as a fertilizer company supervisor from Kolkata, presented with complaints of fever for 2 months, recurrent episodes of giddiness for 2 months, loss of appetite for 2 months, easy fatigability for 2 months. The fever, it was high grade, remittent, associated with chills and rigors. There was no diurnal variations. Now the giddiness, it was episodic and it aggravates on getting up from sitting position. It lasts for about 2 seconds and there was no head rotatory sensation. There was no associated nausea, vomiting, no history of chest pain, palpitations, no history of loss of consciousness. He had a constitutional symptom of loss of appetite since he was unwell. There was relevant negative history. There was no history of weight loss, no history of bone pains, hemoptysis, no history of hematochezia, no night sweats, no history of persistent headache or visual deficits, no history of contact with pets, and no history of night sweats. On examination, he was pale. There was no icterus, clubbing, pedal edema, or no palpable cervical inguinal axillary lymph nodes. All peripheral pulses were well felt. There was a left lower limb hyperpigmentation, which was secondary to the chronic venous insufficiency that he was symptomatic for the past 3 years. And he had dry skin with thinned out hair. He had no comorbidities. Vitals on presentation, pulse rate of 88 per minute, which was regular and with good volume. There was no radial delay. Blood pressure of 100/70, respiratory rate of 18 per minute, and he was afebrile. Further, in the course of the ward, he developed a fever spike, which is as shown in this picture. Systemic examination, cardiovascular system. The precordium was normal. Apical impulse was not visible. Apex was palpable, 0.5 centimeter medial to mid-clavicular line. Normal first and second heart sounds was heard in all areas. Respiratory system, trachea was central. There was no chest deformities. Bilateral normal vesicular breath sounds were heard. Abdominal examination, it was soft. No distension, no localized tenderness, no palpable organomegaly, no signs of free fluid. There was no focal neurological deficits. The relevant lab investigations, he was noted to have a hemoglobin of 10.6 with WBCs of 5,400.
Blessy.
Yes.
So could you just go back and write, what is your clinical diagnosis?
It comes to a classical pyrexia of unknown origin.
Okay. Are there any clues in your history or in your examination which might tell you the cause of this classical PO?
It can be a solid organ malignancy, lymph node malignancies, and infective endocarditis. But
so you said he had remittent fever.
Yes.
What do you mean by remittent fever?
It never touches the baseline of the thermoregulatory system.
So remittent means it stops and then it starts again, right? That's what a remittent fever is. So where do you get fevers and no fever and then fever? Is that the kind of pattern he had? Or it was a continuous fever? What you showed in the graph was that he was afebrile. He had fever and then he became afebrile. So
for
where
a
do you
short
get this
dip.
kind of pattern where you get fever, no fever?
Depending on the duration on how long he was afebrile, like
So which are the
tertian
kind of
fever.
illnesses where you get this kind of pattern? Fever, no fever, fever.
Mm, Chronic granulomatous infections
Yeah.
or
Others,
vasculitis.
what is this? Where you get these patterns of like a relapsing fever. Fever, no fever, fever. What are the kind of diseases? What are the infectious agents which do this? Which are the, sorry, which infectious infection does this? Particularly brucellosis. You have this fevers, no fevers. Which kind of malignancies do this? Huh? Lymphomas, particularly you have got this Bell-Epstein pattern of fever. And the total duration of fever here is
2 months.
2 months. And then on examination, you said he had some hair loss, is it?
Yes,
And he had,
he had alopecia with thinned out skin also.
okay, does that give you any clue to the thing? Or variety of diseases
The
can do this?
comorbid condition like hypothyroidism and
Okay, hypothyroidism.
yes,
Okay, and then you had your blood pressure, which was 100/70.
which is borderline.
And did you check for anything else in the blood pressure when he's a 51-year-old man come with a
The,
100/70?
we look for the postural drop in blood
Was there a
pressure, which was
postural
not there.
drop?
No,
No. And here, so you have, you're thinking, would this be a thyroid problem? But he has no other features of hypothyroidism.
no
So your
hypothyroidism.
diagnosis was of a classical PO,
Pyrexia.
and you're thinking of infectious possibility. You're not thinking of autoimmune possibilities, no?
No.
Doesn't look like that. Neoplastic possibilities. Okay, proceed to your examination, your investigation.
His hemoglobin was 10.6 with a WBC of 5,400, neutrophils was 74, lymphocytes of 17, monocytes of 9, and platelets of 1.92 lakhs. Renal function showed urea of 12 and creatinine of 0.9.
Basically, all your investigations are normal except for the anemia, right? There's a
Some mild
10.6.
hyperkalemia
Yeah, it is a
also.
mild hypoalbuminemia.
Yes,
SGOT is elevated. The alkaline phosphatase is also elevated.
elevated.
So it suggests that there's some kind of a liver pathology which is also going on. Yes. All your cultures were negative.
3 blood cultures were taken. It was negative,
Chest
and
X-ray was normal.
this was the chest X-ray.
Sure.
There was no cavitatory lesions.
Okay. So there's some kind of a chronic disease going on, but the basic investigations are not showing. So you've done the febrile serologies also.
Yes, we did malaria, which was negative. Vidal also was negative.
Sure. But what is C-reactive protein? The
C-reactive was
Brucella
elevated.
serology.
Sir,
Brucella serology
was not sent.
not done. And the ultrasound imaging.
USG
Yeah,
abdomen.
go ahead.
So in the course in the ward, he developed one episode of postural hypotension, which was responsive to fluids. And we've noticed that blood pressures were found to be borderline low side. And followed by which his electrolytes were checked, and sodium of 114 was noted. And subsequently, the serum 8 cortisol was sent, and it was found to be low. And we also wanted to roll out any
So
secondary
7.8 low or it's not? It's
borderline 4 to 12 is not
yeah. So it is,
wanted.
you can't, if it's serum cortisol of less than 5, you can definitely say this hypocortisolism.
Yes.
But here, what you can say is this patient is hospitalized, but the cortisol is on the lower limit. So it doesn't conclusively rule out a hypocortisolism. And the interpretation of your ACTH?
So if it is according to the feedback mechanism, the ACTH is supposed to be elevated, but it was not, as in this case. So central
So what is the
adrenal
normal ACTH level?
should be 12. That.
I don't know the range. What is the normal range? So is it low, the ACTH here? It's lower than the normal range?
Level.
Okay, go ahead.
Subsequently, we did the other hormone parameters of the anterior pituitary hormones, in which it was noted to have a low LH and FSH and low TSH also. Subsequently, T4 FTC was set, and FTC was only 0.3 and T4 of 2.4. Secondary.
So your diagnosis at this stage is?
Central adrenal insufficiency and the secondary hypothyroidism.
Okay, did you do a post-synactin cortisol?
Yes, sir. It was not elevated.
How much was the post-synactin?
It was 12 in that range only. I have not put it.
It was 12, so it did not have a normal response.
Yeah.
So you said that this was a true hypocortisolism.
Yes.
So he has the gonadotrophin hormones are low. He has a central hypothyroidism and a hypocortisolism. So he has a anterior pituitary dysfunction.
Yes.
So he has a pan hypopituitarism, and the posterior pituitary is preserved. So the prolactin was normal, and the brain imaging is also normal. Yeah. Okay.
So we wanted to rule out any structural causes. The brain imaging MRI brain with pituitary protocol, it was negative for any adenoma features, and posterior bright spot pituitary was present.
So what does that mean if there's a posterior pituitary bright spot?
Normal. It is a normal.
It's a normal finding. Okay. So here, let me just ask you a question. So you have a patient who's come to you with a PO, and you found that there is a pan-hypopituitarism. Just to come back to your examination, what additional findings will you look for in your clinical examination to try and find out what is happening? In a patient with hypopituitarism, what all will you look for? On the nervous system, what will you look for? So will you look
There
for a
will be,
bitemporal
hemianopia.
So these are all clinical findings that you should actually look for. So you have a patient with a PO and a pan-hypopituitarism. So what are the pathologies of the pituitary which can cause a PO?
So it can be the structural causes and infective causes.
Yeah, such as most commonly
tuberculosis.
Tuberculosis. So the foremost infection which causes kind of is tuberculous hypophysitis. What else?
Then
Autoimmune
infiltrative.
causes.
There are lymphocytic hypophysitis, which
Very
is
good.
antibody positive.
Yes. What else?
Then malignancies also.
So
that
what
can
about
affect.
sarcoidosis?
Sarcoidosis.
Sarcoidosis and malignancies also, which can involve the pituitary. Proceed.
So diagnosis of pan-hypopituitarism was made. So in conjunctive with the presentation of the classical PUO with the pan-hypopituitarism, our differentials were narrowed down to the one was inflammatory hypophysitis, which can be either lymphocytic granulomatous and IgG4 protein deposition and vasculitis related, or paraneoplastic and infiltrative as in sarcoidosis. So other conditions that we have considered were also a disseminated TB with lymphoproliferative disorder and macrophage activation syndrome also. Now, the relevant investigation that we did was the sarcoidosis. For sarcoidosis, ACE in levels were borderline high, with the calcium was also 9.2 normal. And tuberculin testing was done since it has an energy effect that negative Montaux can in a sarcoidosis. It is extremely sensitive for the diagnosis of sarcoidosis, so which was negative. And vasculitis, we sent the C ANCA, P ANCA, which was negative. And IgG for disease, we looked for the protein level, which was borderline high, 2.75. We also did a bone marrow to look for any involvement of granulomatous changes by macrophage activation syndrome in which can be seen in marrow, which was normal in the findings were normal. Now we also did the whole body PET scan, and it showed lungs and pleura, which has a multifocal patchy peribronchial and subpleural ground glass opacities affecting the right upper middle lobe, right lower and left upper lobe lingula also. And there was the PET showed a nuclear increased metabolic activity in the subcarinal and right hilar lymph node and around the peribronchial GGOs. So now I would like to come to the clinical approach to a hypopituitarism. So the symptoms that we before to the coming to the diagnosis, the patient can present with cortisol deficiency symptoms like recurrent nausea, vomiting, and if it is a structural cause, the patient can have a headache, can come up with if it is a hypophysitis, that is infective patient that like tubercular, can cause weight loss, and they can have giddiness also, and hypothyroidic features like dry skin, cold intolerance, and increased fatigability also. Mm, Other signs that we note is bradycardia, and if the patient is having a sarcoidosis, they can have a lupus pernio and erythema nodosum, and other connective tissue disorder like Sjogren's also, which is found to be causing this hypophysitis, can have a lacrimal gland enlargement and parotid gland enlargement, and they won't be having hyperpigmentation, that is it's since it's a secondary adrenal insufficiency, the ACTH will be ACTH RAS axis will be normal, so ACTH was also low, so no hyperpigmentation. Now the diagnosis of hypopituitarism is abnormal secretion of one or more hormones secreted from pituitary, and the hormonal hyposecretion should be evaluated in any patient who has a cell MRI finding of a mass more than 1 centimeter or a diffuse enlarged pituitary gland, as well as symptomatic with headache and visual disturbance. Now the etiologies, that is apart from this patient, hypopituitarism can be caused by the tumors. The rising can be benign or malignant. Benign can be craniopharyngiomas, malignant metastasis from lungs, breast, and cranial irradiation secondary to radiotherapy. Then traumatic brain injuries. Then infiltrative diseases like sarcoidosis, Langerhans histiocytosis. Then infections like TB, other autoimmune vasculitis, then autoimmune hypopituitarism like lymphocytic, which is anti-PIT1 hypophysitis, and IgG4 related, and empty cell syndrome.
Blessy, since we are run out of time, what is your final diagnosis?
So in this, the metabolically active and the GGOs that was seen in the peribronchial areas, we went ahead with the bronchoscopy guided transbronchial lung biopsy, which showed atypical lymphoid cells which are positive to CD20 and BCL2, and also which is suggestive for lymphoma changes. And currently the patient was discharged with follow-up after a month for planning for biopsy of pituitary to confirm.
So your final diagnosis is a lymphoma, or you're suspicious of a lymphoma?
Yes.
So the marker studies have not conclusive of a lymphoma, is it?
The BCL2 positivity and atypical
So what was the
lymphoid cells.
final diagnosis on the biopsy? What did they put the final diagnosis at? Suspicious of or conclusive of?
It is inconclusive. They told for a repeat biopsy if needed. As of now, we are planning to go ahead with the pituitary biopsy also in the coming month for next follow.
Okay, so did you go back and discuss your imaging findings with the radiologist? Because you're finding no structural disease of the pituitary. So the likelihood that there is some tumor there seems to be low based on your imaging.
Yeah.
But you're saying that there could be a lymphoma. So did you go back and talk to them?
So the lung shows an atypical cells, B cells, so which can have a paraneoplastic activity towards the in the hypophysis, which can cause the
Okay, so
hypopituitary.
there is a suspicion of lymphoma, but overall, do you think he has a lymphoma?
The fever with remittent fevers and
Okay, so none of your other tests have shown that he has a lymphoma, right? So you have these other two diagnoses, which also there, no? Tuberculosis and sarcoidosis. Have you conclusively ruled out tuberculosis?
so the sample, the lung biopsy sample for expert was negative.
Okay, so you're thinking this is not tuberculosis. What about sarcoidosis? You have an elevated ACE levels, your PPD is negative. Your imaging could be consistent with the sarcoidosis. You have hilar lymphadenopathy, and there is some parenchymal lung involvement. What do you think?
But the biopsy doesn't comment on any granulomatous
So you
changes.
haven't. So you actually don't have a final diagnosis right now. You have a gentleman where you're considering still all the three possibilities, and you have decided to follow up this patient. And
Yes,
this case is
next month.
highlighting the challenge of dealing with such a patient of a PO with a pan hypopituitarism. Amit, you want to, any of the consultants who are looking after this patient want to comment? The other consultants, Ramya, Jonathan, Bennett, comments?
When you gave the ACTH, you said the cortisol axis didn't respond, right? Or it did? Synactin test.
7 to 9, it was not more than 18.
So what is your conclusion from that? Technically, if you say the pituitary is not working, you have technically given exogenous ACTH. Why didn't the cortisol respond? Should it not respond? If the problem is the pituitary and the adrenal is fine, should it respond or not?
It should.
But why didn't it respond? Is that consistent with your diagnosis of hypopituitarism? It is, okay. Without the ACTH basal secretion that's happening, the adrenal will atrophy. So after that, injecting synactin will not cause a cortisol response. That doesn't mean the adrenal is not working. Just saying that without the basal ACTH secretion, there is no adrenal stimulation going on for regular cortisol secretion. Okay, so by that you should not conclude that I gave ACTH from outside, so therefore the problem is in the adrenal also. If there's a hypopituitarism, the adrenal will atrophy and you will not get a cortisol response. Okay.
So what are your discharge recommendations? What medicines have you given him?
So we started with the glucocorticoid supplementation, followed by which 2 days later we supplemented him with thyroxine also, and symptomatic management and review for further evaluation.
So you're planning a PET again or a brain imaging?
For a brain imaging bar pituitary biopsy.
After 3 months. And what is remarkable also that he became afebrile after that. Yes, and when you gave the prednisone and the thyroxine, he clinically improved. And he said he was quite well. Okay, thank you very much. We'll go on to the second case.